Things started. Let's take it away to Viva. Oh, wait a minute. So you have done. Okay. Thank you, Dwayne. All right. Take it away. I will stop.
All right, can everyone see my PowerPoint here?
Yes.
Okay, great. All right, well, hello everybody. My name is Geetha Mahendran. I am a dual degree MD and PhD student at the Emory University School of Medicine and also the Rollins School of Public Health. And today, I thank everybody for the opportunity to present our manuscript, Racial Disparities in Adult Cochlear Implantation. And of note, Dr. Vivas, who is the main speaker tonight, is a co-author on this paper, and Dr. Hobson is a PI, and she has been just the best mentor and sponsor I could ask for. So without further ado, there we go. So the authors and myself have no financial disclosures. A brief review of the current literature. Among children who have sensory neural hearing loss, those who are non-white and of lower socioeconomic status undergo implantation at lower and delayed rates. And among adults who have sensory neural hearing loss, those who are non-white undergo implantation at lower rates than white patients. However, the data is limited. Therefore, the goals of our study were twofold: to compare the rates of cochlear implant referral and implantation across patients of different racial backgrounds, and to compare the audiometric profiles across races of patients who are referred for cochlear implant evaluation. This was a retrospective review of patients who underwent cochlear implant evaluation and or implantation from January 2010 to August 2020. We collected demographic and audiometric data, and I performed 2 sample t-tests and chi-squared analyses. We had 504 patients who underwent cochlear implant evaluation, 388 of which met cochlear implant candidacy criteria, and 258 of which underwent implantation itself. Among the patients who underwent cochlear implant evaluation, 68.5% of them were white, which was significantly greater than their representation in the local population and that of Emory's primary service area. In contrast, Black patients were significantly underrepresented. 18.5% of cochlear implant evaluation patients were Black, compared to 51% in Atlanta, 42% in the Emory primary service area, and approximately 33% in Georgia. And these differences were significant. Similar to white patients, Asian patients were significantly overrepresented. They made 12.3% of our cochlear implant evaluation cohort, compared to approximately 4% of Asian patients in Atlanta and in Georgia, and about 8% of Asian patients in the Emory primary service area. And we saw the same racial trends in patients who actually underwent implantation itself. Both white and Asian patients were significantly overrepresented, whereas Black patients were significantly underrepresented. And when looking at standard audiometry scores, we see that Black cochlear implant evaluations patients had significantly worse hearing compared to both white and Asian patients. And the same held true for AZ Bio scores. Black cochlear implant candidates had worse hearing than both white and Asian patients. Interestingly, both Black and white cochlear implant candidates underwent implantation at the same rate, which was in contrast to the literature that was previously studied. So it's important to talk about the factors that play into cochlear implant disparity, and we can think about them in 3 separate buckets: patients, providers, and financial status. Patients who have lower health literacy of hearing care, lower awareness of even the interventions for hearing care, and distrust of medical providers and the medical system at large may not seek adequate treatment or even know how to go about hearing care. And then for providers who have low awareness of interventions and even the consequences of hearing loss, those who practice with unconscious or implicit biases, and those who are operating underneath poorly defined cochlear implant referral criteria may not be referring patients who are appropriate candidates for cochlear implants. And then finally, in Georgia, Medicaid does not cover cochlear implants, and we also have a very large uninsured population. And when you take all 3 of these buckets and you place them together, you get disparities in cochlear implant access and care. And a brief aside about insurance coverage of cochlear implants. As I mentioned, in Georgia, Medicaid does not cover cochlear implantation for adults, although over 500,000 of individuals in Georgia have Medicaid, and another 1.4 million individuals in Georgia are uninsured. And within Emory, Medicaid makes up a very small proportion of our practice. 5% and 7% of audiology and otology patients respectively have Medicaid, and the majority of the Medicaid beneficiaries are Black. So in conclusion, Black patients underwent cochlear implant evaluation and implantation at rates that were lower than was expected based on the representation in the local population and also in Emory's primary service area. And Black patients had significantly worse hearing than both white and Asian patients on standard audiometry and cochlear implant candidacy testing. Interestingly, Black CI candidates underwent implantation at similar rates to that of white CI candidates, which was in contrast to prior studies. And insurance coverage of cochlear implants may contribute to racial disparities in implantation. So here are my references, and thank you so much for the opportunity to speak this evening, and I will take any questions that anyone has.
Thank you. Thank you so much. Wow, that was really interesting. If you have any questions in the chat, or raise your hand and I can unmute you. So do you have enough patients who have private insurance to do the comparison, to do the controlling for insurance stats? Because you mentioned that big part of it may be that 60% almost of Black patients are on Medicaid, and that means they're just ineligible. Maybe those statistics are wrong about the 60%, but it sounds like a large number of Black patients are just ineligible for cochlear implant, even if they wanted one.
Right. That's a really great question. So Dr. Hobson is pioneering the second step of this paper, which is looking at Medicaid beneficiaries and seeing how they compare and if they are actually eligible for cochlear implantation. And so we're currently doing that study at our safety net hospital at Grady Memorial. And Dr. Hobson might have some more comments on that as well.
Dr. Hobson, I allowed you to talk if you want to weigh in, but I guess that's the next question I was going to get into about Grady. How do you do a lot of cochlear implants at Grady? Because I'm imagining that's a lot of patients are on Medicaid at that institution.
Dr. Maddox previously did cochlear implants at Grady, but then I don't remember exactly how long ago, some time ago, the Medicaid benefit changed because they previously did cover cochlear implantation and now don't. And so there's no cochlear implants that are done at Grady at this time. And so the study that we have ongoing at Grady now is looking at patients. We just kind of picked an age range, so under 65 ineligible for Medicaid, and looking at their audiometric profiles and looking to see who may meet criteria for cochlear implantation. So there's a few studies out there looking at just standard audiometry and which patients are likely to meet CI criteria. So there's a new 60-60 rule, where if the PTA is greater than 60 or the speech discrimination word recognition is less than 60, those patients are likely to meet CI criteria. So we're looking to see how many patients are coming through who might meet criteria, but cannot be or are not being referred because of their insurance.
And do you guys see, you mentioned that African Americans or Black patients, even their hearing was worse. Is that something unique? I haven't heard of something like that before.
I think something similar was shown on a study a year or two back. I can't remember if they were looking at the standard audiometry or the CI candidacy criteria. I think it was looking at AZ bios, and similarly showed that Black patients had worse hearing, but hadn't been shown on standard audiometry previously. But the PTA difference was like 80, I don't remember the exact numbers, Geetha, 83 versus like 74, something like that.
Yes, it was about that. Yeah.
And the speech discrimination similarly was significantly different.
Wow.
It could also mean that, sorry. It could also mean that, these patients are being referred until they're much in worse shape than others, right? And so they're presenting at a much more advanced hearing loss then others could have been referred,
Right.
earlier.
Exactly right. And so that goes back to Geetha's kind of root cause slide. So why are they being referred later? Is it provider bias? Is it the patients don't, trust healthcare providers and they're waiting until they're desperate? Hard to know why they're being referred so late or presenting so late. What we don't know is, if people are being referred and are choosing not to undergo CI evaluation, or if they're not even being referred. So we don't know why there's that difference.
Dr. Talker, she said, what are some tangible intervention points that can be feasibly acted on by surgeons in the field?
Well, I think that's a great question and goes back to Dr. Hobbs's point of us not knowing exactly the scope of what's happening behind that portion of decision making. But interestingly, I don't know that it's right on the onus completely of the surgeon itself, but on that primary care aspect as well of catching people earlier. The USPSTF guidelines don't recommend for or against hearing screening. So a lot of primary care doctors aren't doing it unless it's brought to their attention. So maybe a level of heightened awareness about what to do and then what are your options thereon. But it's a very complex discussion too.
Okay, outstanding. Thank you so much. So let's bring on Dr. Vivas.
Okay, we're gonna change gears.
Take over.
All right. Very different topic. Can you guys hear me?
Yes, we can. And we can see your slides. They look perfect.
Great. So changing topic here, shifting gears. So just I have no disclosures and a little bit background. I am Colombian by birth, but raised in New York, where I've done most of my training, and ultimately did fellowship in Pittsburgh, where I met Dr. Hobson, and I came directly from fellowship to Emory, where I've been here since 2013. And I thank you all very much for the invitation today. So let's start off by terminology. The idiopathic intracranial hypertension is the more common term we use now, but it has not always been that. It's gone through different names. Most of us probably don't remember it being referred as serous meningitis, but we do remember the term pseudotumor cerebri and even benign intracranial hypertension. Well, benign intracranial hypertension was ultimately renamed because it's not so benign. There's obviously morbidity associated with this diagnosis, and has now been shifted to try to standardize it as idiopathic intracranial hypertension. Pseudotumor cerebri, however, is still used, but under very specific circumstances when there is an actual underlying, whether it's metabolic or syndromic cause for the intracranial hypertension. So today we're just gonna focus on IIH, which is truly idiopathic. So what is the implications of this diagnosis? The general population is anywhere from 0.5 to 2 per 100,000. It really is geographically dependent. We will see a graph that helps to illustrate that. But what we do know is it is very much a young women's disease. And in that demographic, we see anywhere from 12 to 20 per 100,000. So significantly higher in females, and typically diagnosed in the second and third decades of life. And what we have seen is that the incidence is overall increasing because the rates of obesity in the world, and particularly the US, has really been on the rise. And there is this linear correlation between obesity and the development of elevated intracranial pressures. And so it's almost like this is from a paper published in 2012, and I thought it was a nice representation of just how the body mass index correlates with your CSF pressures, your intracranial pressures. So you can see that the heavier you are, the higher you are to have elevated intracranial pressures. So one thing that I think is important to emphasize is that obesity has been increasingly seen as an inflammatory disorder, and there are numerous cytokines, specifically the adipokines, that are implicated in obesity. And so there are markers of inflammation that have been looked at in patients who are obese, and specifically within their CSF, and they have found elevation of some of these inflammatory markers be much higher in patients who have elevated, who are obese and have these markers compared to control. So meaning that there are inflammatory markers found in the CSF of patients who are obese, and speaking to kind of this inflammatory reaction that goes along with obesity. And so we are the fattest country. We like to be #1 in the States, right? But we are really the fattest country in the world. And you can see the little sad mark is Georgia. We have a 30 to 35% obesity rate in the state, as opposed to the West Coast, the happy face in California. These, you're not going to see as much as IIH patients in that part of the country, but we see a lot of these folks down here, and the way we see them, I'm going to go into that. So what is the proposed mechanism? Well, the thought is you're heavy, you have a lot of body mass, and that in turn increases your intra-abdominal pressures, intrathoracic pressures, and that in return elevates your central venous pressure, and that interferes with your CSF absorption. And that leads to intracranial pressures that are elevated. Now, what is the problem with that? Because it totally makes sense, right? You look at them like, oh yeah, that makes sense. Well, the problem is that it doesn't explain why it's mostly in women. So there is some sort of, hormonal effect that we just are not very clear on, but there might probably some gyneco fat, hormonal influence, and it's something that is really still not very well understood, but we know that it's not as obvious as the left side of the screen. There's something else going on that is triggering this problem, particularly in women. There was a large meta-analysis that looked at numerous studies listed on the left side, and they summarized the most common symptoms in these groups. And there was no surprises there in terms of the most common symptom being a headache, and whether it's associated with nausea or not, or photophobia. So you can see up to 94% in this meta-analysis, up to 94 of these patients presented with headache. But the other things that are relevant to otolaryngologists is that these patients also had pulsatile tinnitus, up to 60% of them. And the pulsations, be mindful, they can be unilateral, they can be bilateral, they can go back and forth. They also have dizziness, all right, and they have neck pain. So there's obviously visual changes. And so those, for us, headache, think about how many patients you see with migraines, dizziness, and pulsations in their head. So that's something that we definitely comes through our doors. Maybe not the pediatrician's doors, but definitely on the adult side. Now, there was a very large multicenter, double-blind, placebo-controlled trial that looked at IIH patients and specifically looked at their presenting symptoms, like related to the slide I just showed you. But this is more like a visual representation. And what that multicenter trial looked at was the effect of acetazolamide and visual improvement of visual symptoms, as well as control of the intracranial pressures. And we won't go into that very much. We don't have much time, but just remember, for us, headache, pulsatile tinnitus, dizziness, neck pain, those are some of the more common symptoms seen in these patients. And the first case was actually described by Dr. Dandy in 1937. And what was interesting is I actually read through most of these case series. And he summarizes at the end, it's like, we just really don't know what is going on. You know, he's like, it is unknown, and it's still kind of unknown. So many years later, we still don't quite understand exactly what's going on and causing this problem. So not too much improvement overall when you look at the bottom line. But what is, you know, what are the symptoms we talked about? So what are the physical exam findings? And classic criteria for a diagnosis includes papilledema, which is the swelling of the optic nerve. You can have, in more advanced cases, nerve palsy, abducens nerve palsy. But the key thing here is that you should have a normal neurologic exam, meaning other than the cranial nerve deficits from the abducens palsy, you shouldn't have any other neurological deficits. And the CSF composition is normal, meaning you don't have any bacteria, you don't have any signs of like an infection or inflammatory reaction. I'm not talking about the cytokines that was mentioned earlier, but just regular stuff we look for in terms of like meningitis and other things, you know, malignancy, that kind of stuff. And the pressures, you know, you can find various sources, but most people go with more than 25 centimeters of water pressure. You can find other references that say it could be as low as 20, still considered abnormal. And so the current management is weight loss and lifestyle modification, which is very difficult. As you guys know, losing weight is just very, very hard. And therefore, medication usually comes into effect. The most common use is the carbonic anhydrase inhibitors, acetazolamide, Dimax. Has side effects, so it's not always very well tolerated, but Topamax can also be used. It's also something that it's a weak carbonic anhydrase inhibitor as well, but it's also used more commonly when the patients have a lot of headache. It's a migraine medication as well, but it induces weight loss. And so that's how it comes into play here. And then the other two medications at the bottom, those are actually repurposed medications that are not, you know, they're used off label, and they were developed for management of diabetes and weight loss with diabetes. And so they are being looked into as repurposing for management of these patients as well. So it's, now the final and ultimate, you know, treatment is the CSF diversion. So some of these patients have to get shunted, right? Have a VP shunt most commonly. So now, now we have a new way to diagnose IIH, because most patients, well, not most patients, but there was a group of patients that just didn't have papilledema, but they had a lot of the other symptoms and even radiographic findings consistent with elevated intracranial pressures. So in 2013, there was new criteria proposed to make a formal diagnosis of IIH, and that involved, you see number 1 and number 2. And number 1, so that's a classic criteria. So you've met all of those, A through E, you can have a formal diagnosis of IIH. But if you do not have papilledema, then you can meet some of the criteria number 2. And those are mostly radiographic criteria, which we're going to go through. So that really helped kind of make a formal diagnosis for some of these patients that did not have papilledema, but had lots of other things that were consistent with IIH. And the radiology of this, I think, is really fun to look at these pictures. So they're really pretty pictures. And so we're going to go through, you know, from some very common things to some more unusual for our specialty to be looking at. Empty cella is by far the most common finding in these patients. However, it is not diagnostic. So you'll find lots of, you know, patients that'll have an empty cell on imaging, but it's just, you know, it's a finding. It doesn't necessarily mean that they have IIH, but within the IIH group, this is by far the most common finding. In terms of things that are more unusual for our specialty, but I think it's worth looking at least once. Once you've seen it, it's kind of nice. You might be able to pick it up on your own, is the orbital findings. Now, the orbital findings can be very subtle, but I'm going to show you some not subtle findings. And the posterior globe flattening is one of them. And so here you see this should be perfectly round, but the posterior part of the globe here has flattened out from the pressures that are coming from behind the eye. And you can also get optic nerve sheath enlargement. This is a pretty obvious thickening of the sheath here. And you can get, oops, I'm sorry. Let's go back. Oh, I'm giving away all the good stuff. Oh, I'm having technical issues here. Well, you can have tortuosity of the optic nerve sheath, which is pretty neat if you can see that. And it's not very difficult if you have an MRI that captures the orbit. So if you can see this, the nerve is pretty tortuous instead of being, should be straight, right? Okay, so in terms of skull-based findings, that is more of like our territory now, right? This is a pretty drastic picture I'm showing you because it literally looks like it's a mouse has gone in there and bitten away at the bone. There's really diffuse scalloping of the skull base, and those are thought to be secondary to chronic pressures against the skull base and formation of granulation arachnoid pits. And that can lead you over time into osseous defects. And so we can see those whether you're in you know, in a subspecialty within ENT or rhinology, otology. You can have meningoceles presenting in the anterior or lateral skull base. And then, you know, those can eventually develop into CSF leaks. You can also have enlargement of the foramina of the skull base. Now, in terms of the meningoceles, they can come into different parts. You know, the anterior skull base over the cribriform is a very common one, but then you can also see them in places like the petrous apex. You can see them at the geniculate, meningocele there. You can see them Meckel's cave. You know, I mentioned enlargement of the skull base foramina. This is rotundum here. And so it's, you know, there's lots of different radiographic findings that you can find in these patients that are kind of neat to, you know, to recognize. Now, one thing that is not necessarily within our specialty, but I think is really important whenever you're talking about IH patients, is that it's not unusual for these folks to appear to have low-lying cerebellar tonsils on MRIs. And remember, a lot of these folks have headache, and so they tend to get MRIs. And sometimes they are erroneously diagnosed with a Chiari malformation and they get surgery and then don't get better. And the reason is they really didn't have a Chiari, they had IIH with the low-lying tonsils. And so it's just, you know, something interesting to know about, even if we're not really managing that specifically. Now, something that comes into play for us is this transverse sinus stenosis in these patients. I'm going to go through some of our study findings regarding this, but you know, basically you see it in typically bilateral in these patients. And it could be, you know, something that is fluid. It can be reversible, and sometimes when the pressures get better. And again, it's usually bilateral. Now, these are arrows that are showing the stenosis in a venogram. All right, so focusing a little bit more of IIH complications in the ear. So, you know, we have two pictures here, and they're both very abnormal ear drums, right? And there is a middle ear lesion on both of them. One of them is a meningocele and one is not. And so we're short on time, so I can't quiz anyone, but the one with the meningocele is this one. And this patient I treated several years ago that had been treated for an otitis for an extended period of time, kept getting antibiotics. You know, she felt she had pain, she had pulsing in the ear. And every time they looked in the ear, they just saw redness, and they kept telling her she had an infection. Ultimately got referred to us. And I wish I had a video, but this was an obviously pulsing mass. And the MRI is on the right side. She had an encephalocele filling pretty much most of the middle ear. And she was a patient who was ultimately diagnosed with IH, and actually after repairing the encephalocele, she had to get a shunt because her pressures were uncontrolled. So what is the thought of the pathophysiology of IIH, encephaloceles, and CSF leaks? Well, the thought is you have these chronically raised intracranial pressures that form arachnoid pits at the skull base that ultimately erode the bone, and you get dural thinning over time, and eventually it kind of pops and you get a CSF leak, right? So that's what we believe happens. And what we did is we looked at, probably 4 to 5 years now, we put together a study group between the neuro-ophthalmology group at Emory and us, because they see all the IIH patients and we just see the ones that have CSF leak that we think some may have IIH. So what we ended up is we formalized our pre-op and post-op care for them that always involved ophthalmology when they came through us for CSF leak management. And so what we did is all of the patients that we saw for CSF leaks, spontaneous, we had them evaluated by neuro-ophthalmology, and they got thorough evaluations from their standpoint before and after surgery. And then we followed those patients very closely, often started them in acetazolamide managed by ophthalmology. But then we also standardized their preoperative workup, meaning we got, because some people were getting CTs, some MRIs, some MRVs. And so we all decided to kind of streamline our workup for these patients so that we can learn more about their underlying disease. And so we started getting MRVs consistently on all of our pre-ops. And that has been 4 or 5 years now. And we published some findings not long ago. I think this was, last year. And what we found was that, unlike the findings with their cochlear implant patients, most of, mostly women, that's not unusual, but 50% of the patients were Black. And so that's, I think the population, African-American population in Atlanta is about 53%. So it's kind of in line with our, with that at least. And, consistent with other findings, most of these patients were obese. The average BMI here was almost 37. Of this group we looked at, almost 40% presented specifically with ear symptoms. And interestingly enough, the optic nerve exam was normal in 80% of them. So these patients are not having papilledema, right? Because the thought is they're relieving the pressures by their CSF leaks. And so their eye exams were predominantly normal, and most treatment that was instituted after surgery was acetazolamide. So when we compared the definitive IIH patients that went through the ophthalmology service and compared it to the group of patients that we saw for CSF leaks, we saw some interesting things. First of all, at this point, we'd only gotten 25 patients with an MRV. Now we have a lot more, but, the majority of patients had bilateral stenosis of their transverse sinus, which is not something that we're really, we're expecting to find in these patients that technically are relieving their pressures by having a leak. And the majority of them had an encephalocele, so 90% of them. Whereas if you look at the IIH patients in this column, the minority had encephalocele. If you just had, definitive IIH, but no signs of a CSF leak, to just standard IIH patient that gets followed in ophthalmology. The minority of them had this, encephalocele, which would have been an incidental finding on imaging. And the majority, 96%, had bilateral sinus stenosis. So that's definitely something that was interesting. Now I went back and I looked at specifically that study included the anterior lateral CSF leaks. So I went back and I just looked at the group of patients that were treated only for CSF leaks to the temporal bone. And we had treated 120 patients over almost a 10-year period. And 99 of them had gone through a surgical repair. And we had a decent follow-up, about 15 months. And there were many differences compared to the bigger cohort. Still majority of the female, here's the racial breakdown, and the BMI was similar at 35.78. We treated most of them using a middle cranial fossa craniotomy. I think I definitely favor this. And I usually work with our neurosurgeon and with the access, but the minority of them required a combination or just a transtemporal surgery, and very few of them required a shunt. So of the 99 patients, only 5 went on to require a permanent CSF diversion after surgery. Now, a couple of these were done concurrent to the CSF leak repair, because either one, they already had a diagnosis of IIH, or we were so sure they had IIH that we didn't think that these patients were going to respond to treatment. Usually that decision was led by the neuro-ophthalmologist, because they saw already worrisome ophthalmologic changes even in the setting of a CSF leak. Those patients usually ended up getting shunted at the time of the CSF leak repair, but it's a minority. So in terms of looking at the MRV findings specifically for CSF leaks to the ear, we saw that 56% of those patients had bilateral transverse sinus stenosis, and surprisingly, 46% had some sort of optic sheath dilation or Meckel's cave dilation, speaking to maybe pseudomeningocele into Meckel's cave and previous edema, perhaps from IIH in these patients, or undiagnosed IIH at the time. All right, and so when it comes to IIH, most patients are not going to have CSF leaks, right? There's an association between IIH and CSF leak incidence, but again, we don't have a direct correlation of how this happens. But you see these patients with pulsatile tinnitus probably a lot more often than you see a CSF leak, depending on where you live. And so we have a protocol here that's unique to us, but the differential for pulsatile tinnitus is there. You can see it. It's vast, and a lot of it can be figured out by a physical exam and a history. But the algorithm can start depending on who's ordering the first study, whether it's a neurologist, primary care, generally ENT, subspecialist. That most of these patients end up getting a CT and MRI at some point, or even an ultrasound in the neck, because they're thinking, do they have carotid artery disease? But it's important to keep in mind that when we're seeing for pulsatile tinnitus, we think glomus tumors, maybe it's an encephalocele, but maybe it's just IIH without having any of the other otologic manifestations. And those patients, taking a thorough history, looking at, they're taking they're female, they're younger, the patients that have true IIH are younger, 20 to 30th decade of life. The patients who are presenting to us with CSF leak, encephaloceles, and that problem, they tend to be older and 40, 50 years old. So there's a big gap difference there in age. So I am finishing. I talk very fast. I'm sorry. I want to make sure we had enough time for questions. And so in summary, IIH is rising in incidence worldwide. And so we have to be, we just got to keep in mind that we may be seeing more of these patients. The etiology of IIH is not entirely known, but we do know that it is directly related to obesity. And being a female puts you a risk factor. And we keep in mind that there is this association between IIH and spontaneous CSF leaks, and that we are seeing more of these patients that are requiring surgery to address these leaks, and that we are going to be, just like it or not, we're going to be seeing more of them. And I am happy to take questions.
All right, thank you so much. That was that was great.
Sorry, I thought it was going to take me a little longer. I talk so fast.
No, that's okay. I'm sure everyone will enjoy the rest of their evening. I'll keep a lookout for any questions. One of the things that, obviously I'm a pediatric otolaryngologist. I haven't seen any of these cases posted at Children's, but I do when we have our M&M, these cases come up quite frequently. And
oh,
so
really?
do you see more complications? So if you do a middle cranial fossil approach for an encephalocele in a patient who has IAH, do you see more complications, or you think, are they similar? I know you had a slide, but I didn't catch that if you talked about the complications.
So I presume that almost all the patients I see with idiopathic CSF leaks have IH. I presume that from the get-go, and then I kind of talk my way out of it. But what we see in these patients that have chronically raised intracranial pressures that end up developing a leak is that the dura is extremely thin. And so what happens in those cases, and this is one reason I really like to do it as a team-based approach with our neurosurgery colleagues, is that they are much more prone to have dural tears during surgery and potentially bleeds. And also these patients, some of these, you have to use more retraction in the temporal lobe, and that may lead to some aphasia post-op. And I've never had anyone develop a seizure, but sometimes for those who really had a swollen, we call it a hard brain, when you open it up, you can just feel the pressures. Sometimes we actually put them in seizure prophylaxis for several weeks that neurosurgery kind of manages. And so technically, yes, these patients do have a higher risk of having a complication from something like a middle cranial fossa surgery.
Okay. Are you having to do more, put in more lumbar drains, or is that just something you guys automatically do? Occasionally there'll be controversies whether I just do a lumbar drain or not.
We stopped doing the lumbar drain. I would say almost 7 years ago. Actually very soon after I arrived, the neurosurgeon that I work with and I started literally on the same day. And so I think it was like a year into our practice, we're like, we're getting a lot of problems, radiculopathies and other issues with the lumbar drains, both in these patients and in our other skull-based patients, the schwannomas. Mm-hmm. And there was, I think in general, has been a move to shy away from those. Instead, we put them on acetazolamide post-op.
And are you seeing not just the increased incidence of these problems, but obviously we're not just, the proportion of population is not getting getting heavier. We're also getting heavier, and like the people who are heavy are even heavier. The BMI is, it's not uncommon. Even in pediatrics, we'll see kids with a BMI of 50 sometimes. And are you seeing, are you seeing even worse problems in that? So you're seeing idiopathic hypertension, but are you seeing it's even worse now than what you've seen 5 years ago in terms of the severity of illness?
Well, the overall diagnosis of IIH, I'm not sure. It'd be interesting to speak to our neuro-ophthalmology colleagues to see if their overall diagnosis rates have increased. But I would say that the rate of CSF leaks that have come through the doors over the last 8 years, how long I've been at Emory, has not dramatically increased, but has slowly increased over the years. It's not like it's been doubled, the rate, but definitely we saw a decrease over the last year and a half, pandemic related. I think access and just things have been, people who, because you got to think about how these patients get diagnosed with CSF leaks. Oftentimes it's intermittent. So they may get just fluid in the ear. Sometimes they'll get a tube and then it may leak, may not leak. Sometimes they leak profuse. Those are the really ones that end up going to the hospital quickly. And so in the last year and a half, I think we've been a little off because of the pandemic and access and stuff. People just been putting off care. But I mean, overall, it's been a steady increase, but nothing that's been dramatic.
Okay. And then Dr. Myers just mentioned that these would probably be great oral board questions. Anyway.
There you go. I can give you some slides to write some questions.
So, okay. Well, any other questions from the folks? This was outstanding, and I'm sure everyone's happy that we still got plenty of time to enjoy our evening. Just a couple of reminders. Again, no meeting next month. We'll meet again in January, where our guest speaker will be Dr. Taylor. And I hope everyone is safe. Happy holidays. We'll see you all soon.
Well, thank you again so much for the invitation. It was great to be here.
Thank you. And Giva, good luck.
Thank you.
All right, bye everyone. I'm going to end the
Bye.
meeting.